Um, so welcome, Mike. It's a great pleasure and a delight to be talking to Mike Rigby today. He is one of the leading lights of pediatric cardiology and has had a career that spanned several decades and overseen an immense shift in how children's heart disease is diagnosed, treated, and prevented. And so it's a real pleasure to hear from Mike today. Um, Mike, give us a short introduction about yourself, where you are, and yes, and what you do now.
Well, so currently I'm a consultant pediatric cardiologist at the Royal Brompton Hospital, which is now linked with Guy's and St Thomas's. And this is where I've been since 1979. And I've grown up through all the eras, really, or most of the eras of pediatric cardiology. I guess if I go back to the beginning, so I arrived at the Royal Brompton Hospital in 1979, having come from the Toronto Children's Hospital, where I'd had a Canadian Heart Foundation research fellowship. So I was training there, doing some research, applied for a job at the Brompton because I noticed from publications I was reading, particularly from Bob Anderson and Elliot Scheinborn and Chris Lincoln, there seemed to be quite a lot of interesting stuff going on there. And I was avidly reading about primitive ventricles and naming of congenital hearts. And I thought, well, maybe that's a good place for me to apply to. So I applied, I got shortlisted. The day before the interview, I think I'd arrived in London on a flight from Toronto, I think via New York, because it was cheaper. And I spoke to Elliot Scheinborn and I arrived and said, could I come and talk to you tomorrow and see you before the interview? And Elliot said, well, you could do, but we've really already decided who we're going to appoint. It's hardly worth your while, he said. It's true, he said, it's hardly worth your while. Anyway, I bought the ticket. I was in London, staying with friends there with my wife. So it looked like I wasn't going to get the job. So on the day of the interview, we decided to go out for lunch to a very nice restaurant in Chelsea down the Fulham Road called San Frediano's. And we had lunch and we shared a bottle of white wine between us. So I had half a bottle of white wine, a very nice lunch, strolled up to the boardroom at the Brompton Hospital at 10 to 2 to be ready for the interview. 8 people were being interviewed. 8 people. It crossed my mind, well, it seems slightly strange to have already decided who you're going to appoint and then interview 8 people, but that was that. Anyway, at the end of the interview, which went very well, I recall. Maybe because I was slightly tipsy, I don't know, but it certainly went. And I
All fearless.
had plenty to say. I'd written a few things, I'd been working in Toronto in Canada at a prestigious institution, so I had plenty to talk about. Anyway, I got the job. And I think the favoured candidate, to best describe him, will be rather boring and dull. So I think the fact that I was more entertaining and sounded more interesting got me the job. So when I arrived at the Brompton, I looked round and it was a terribly old building. Remember, much of it was built in 1840, 1880. Terribly old. In fact, I thought, what have I come to? But I very quickly realized that being in an old building compared to the Toronto Children's Hospital, which was relatively modern, I realized that there was plenty going on that was interesting. It was busy. And there were some great people there. Not only Elliot Scheinborn and Bob Anderson and Chris Lincoln, but also the head of Echocardiography, Derek Gibson, was very helpful to me, and as was the head of the cath lab, Graham Miller. So I got on well with those key people right from the beginning, which was always helpful. And I mean, when I arrived, there was not a 2D echo machine. There wasn't one in Canada, in Toronto, when I was there, so it was very new. Anyway, Derek Gibson
Mm.
generously bought a new echo machine out of his own money, £100,000. He was obviously quite rich.
Wow.
I think he was a rich family, had big private practice, and he put all his private practice money into a fund, and he brought an echo machine for the Brompton. He said, Michael, if you want to use the echo machine, feel free to use it any time after 5:30. So 5:30 in the evening, I'd take some children down and what have you and do echoes and practice. I was
Hmm.
already a very good at what we called M-mode echocardiography, but 2D was quite different. Anyway, I learned quickly. Started publishing a bit, showing off, giving lectures and that kind of thing, showing my 2D echo skills. And that was kind of the beginning of my career. I should just say, it was hard work. We were,
Very hard
I
work.
was on one, I was on 1 and 2. There was a registrar and myself
Mm.
working 1 and 2 on call. We had 3 SHOs, and we covered the intensive care unit and the ward and the emergency admissions and everything. So it was tough. Thankfully, I had uh, a very helpful and devoted wife who subsequently also in the 80s looked after our children very well, whilst I was neglecting them all really and working and traveling to some extent.
Yeah. I mean, it was a different era, wasn't it? And going to the Echo story, because of course now technology is amazing, but just let's stick to the 80s for a second whilst you're arriving, and really the art of echo as a modality is only just emerging. And for those of us who don't know what that is, maybe explain what is an echo, Mike? What is it, and how is it used, and what did people do before it existed? How did you look after children with heart disease before echocardiograms were as ubiquitous as are some of the other modalities, which we'll come to later? How did you do it? And talk us through about that. Tell us a little bit about the power of echo and its role in children's heart disease.
Yes, so let's remember that now two-dimensional echocardiography with a bit of 3D is the basis of diagnosis, and the quality of imaging in infants and small children is fantastic, much better than you may find in many adults. But at
Hmm.
that time, in 79, there was a stethoscope. You can examine the patient, use your stethoscope. We had a chest X-ray, we had ECGs, and we had diagnostic cardiac catheterization. There was one lab for the whole of the Brompton for adult and pediatric um, diagnostic cardiac catheterization. So emergency cases, they were admitted. Imagine an emergency baby comes in at midnight, severely cyanosed. We made the diagnosis with with angiography and clinical examination, looking at the chest X-ray. And
Mm.
if necessary, we did urgent cardiac catheterization in the neonate, which required a certain amount of skill. And so that's how we initially did it. And then echocardiography began to emerge together with intravenous prostaglandins, which could be used to keep some of these sick babies in a reasonable condition whilst you investigated them and made the diagnosis.
Hmm.
So that so I know, and then we were working, you were up on the intensive care unit quite often, and then working a normal day the next day. So life was not all that easy.
No, no, very difficult. And so, and now, of course, echo is something that is used literally in every day, every case, every time you are going to examine a baby with heart disease. What other investigations are there now that there weren't before, and how has that changed how children with heart problems are treated and diagnosed? What can we do now, and what have you seen change over those years?
Well, the fundamental diagnoses are still based on echocardiography. But the additional things that we have now are MRI, and particularly in the small babies, we have cardiac CT, which gives low radiation dose now. In the early days, the radiation dose was high, low radiation dose, and gives you additional information about things like the pulmonary veins and the peripheral pulmonary arteries and things that you may not be able to see well with echocardiography. So
Mm-hmm.
it's the I's, crossing the T's, getting a precise diagnosis. Of course, other things have improved, the quality of cardiac surgery, the cardiopulmonary bypass techniques, all that kind of thing. Everything gradually improves as the years and months go by.
Mm-hmm.
Um, um, it's not only the imaging, it's the delivery of treatment and the delivery of the service, anything. Of course, we have specialist imaging people, specialists in magnetic resonance imaging and CT also. But
Mm.
um, I think quality of everything has gone up. Techniques are better.
It keeps improving, doesn't it? And tell us a little bit about the difference between interventions that you will do on children with heart disease versus an operation. What's the difference, and who does what? Who does
Okay.
a intervention and who does surgery? And how do you decide which one you're going to do?
So when I started, the only interventional procedure that we did for congenital heart disease was balloon atrial septostomy for
Hmm.
newborn
Tell us
babies.
tell us what that is.
For newborn babies with transposition. So it's a technique going from the vein at the top of the leg in the groin, passing a balloon catheter into the heart, blowing up the balloon and tearing a hole in the atrial septum between the two of the chambers in the heart, the two top chambers, the atria, creating a hole to allow mixing of blood to make the baby much less blue. Still blue, but much less blue. And that allowed time to the next operation. In the early days, the next corrective operation for transposition would normally be done about the age of 4 to 6 months. So
Hmm.
creating that hole, the baby dying within a week, the baby would then survive for a few months to have an operation, a sort of corrective operation done at 4 to 6 months.
Hmm.
But that had been around I was doing that when I was in Toronto, balloon atrial septostomy, but it's still a very specialized procedure, not without complications, and takes a certain amount of skill to do it well. So that
Yeah.
was the early one. Then, during the 80s, round about 1986, 87, people were introducing other techniques of keyhole procedures using the veins and arteries in the groin at the top of the leg for other procedures, particularly the treatment for severe pulmonary valve stenosis, an obstructed valve in the heart,
Hmm.
sometimes for uh, children with complications of surgery, recoarctation of the aorta in babies. We were redilating where the surgeons had operated on to
Mm.
relieve some secondary obstruction. Again, a good procedure. So they were the early procedures: balloon aortic valvotomy, valvuloplasty for severe aortic valve obstruction. So those were the earlier procedures, which
Hmm.
were in the late, early 80s. Still pretty experimental, though.
Mm.
People like me were self-taught. It
Mm.
was the era of the self-taught. Of necessity, to some degree, you had to experiment on the patients to learn yourself.
Because there was no precedent. People didn't know how to do it. No one had done it before. So there was always
Correct.
this discovery phase.
Correct. Or there are a few people doing something and they'd write it up in the journals, or you'd see them at a meeting presenting stuff, and you think, oh, I could try doing that.
Yeah. Yeah. And how about operations? How is that? if you sort of think back to when you started sort of in the 80s,
Yeah.
and then now, what were the operations then and what are the operations now, and how has that changed? How is the patient population different? Survival rates, I suspect, are different.
They are. I mean, a lot of the operations are surprisingly similar. For complete transposition of the great arteries, the standard operation was called a mustard operation or a Senning operation. The newer operation, the arterial switch operation in newborn babies, was first done in 1983. So you switch the great arteries round, and the baby who was a few days old had to re-implant the coronary arteries. There had been some previous surgery in older children
Mm,
for transposition using an arterial switch operation who'd had previous palliative surgery. So the first arterial switch operation was done in Brazil in 1977 by a very good Brazilian surgeon in Sao Paulo and called Adib Jatani. And then Magdi Yacoub started doing that at Harefield round about the same time. The neonatal switches we started doing at Harefield and at the Brompton in 1983. Again, very early. A lot of places weren't doing them then.
mm. And what about now? What are the in some ways commonest children's procedures and operations that are done? And has that changed? Are there things that you can manage without an interventional surgery now that you couldn't do before?
Yes, but they tend to be the simpler things, percutaneous closure of atrial septal defect,
Hmm.
balloon,
Hmm.
balloon angioplasty and stenting of coarctation of the aorta in older patients, children, adolescents, young adults. I think the greatest kind of progress really is the implantation of a new pulmonary valve and new aortic valves, but new pulmonary valves,
Hmm.
particularly in children, adolescents. These are children, however, who've had previous open heart surgery for complex conditions, including the insertion of a tube with a pulmonary valve in it. And then when that valve begins to fail after a number of years, we can then
Hmm.
go just put in a new pulmonary valve in the tube where the old pulmonary valve is, and we just stretch everything up and fracture the conduit a bit. I mean, as you can imagine, it's not a walk in the park. It's not a particularly
Mm.
easy procedure. Works very well. So percutaneous valve implants, pulmonary valve, aortic valve, and now in adult practice, they're even putting in mitral valves and aortic valves in older
Mm.
patients. We don't use them in children, but in older patients, because aortic valve disease, for example, is a disease of the elderly. And
Yeah.
so this great technique, avoiding open heart surgery, implanting uh, arterial valves inserted through the arteries in the legs or the neck.
Mm. That's amazing if you think about it, that these were operations, I should say, where you'd had open heart surgery, big operations,
Yeah.
right? Breaking chest open, all of those sorts of things. And actually now it's all shifting
Right.
endoscopically, percutaneous, which means basically through little, sort of catheters. So it's a real change. How has that
Yes.
changed the mortality and basically the survival rate in children? So what was it like, in some ways, what was it like for a child with a being born with a heart condition, in the late 70s, early 80s when you started at the Brompton, and now, what has moved on so massively? Because of course there's better diagnostics and there's better surgery and better interventional capability. But what does that mean for the child in terms of survival and good quality survival?
Well, it does. I mean, you're right. On the whole, the surgery is better, although there are some operations that were done in the past frequently by the old surgeons that the modern surgeons don't do quite so well because they do them very infrequently. But on
Mm.
the whole, But the other thing that has improved, as I've already mentioned, is just the quality of cardiopulmonary bypass. The way the
Mm-hmm.
tissue, everything is handled during the operation. Because sometimes, the operation could be done well, it looked very good, but the child died or the baby died of the complications of cardiopulmonary bypass itself. The open,
Mm-hmm.
you have to reroute the blood through a heart-lung machine, which takes over the work, the pumping action of the heart and the oxygen transfer. And those kinds of procedures are fraught with potential complications. Well, the complications of those things have got much lower. So it's unusual for an infant to die because of the cardiopulmonary bypass. And
Mm-hmm.
things have improved, I guess, for surgical skill, the stitches and all and the materials used, and the to, but a, a lot of the operations are basically the same. There are a few new ones, not so many, to be honest.
Mm-hmm.
It's just all the things that go with it,
Yeah.
better, slightly better diagnosis, so the surgeon doesn't open the chest not knowing what the operation is now, which sometimes happened in the past, or with the wrong diagnosis.
Mm.
So they have to think on their feet. But if you open the chest expecting to do one operation, then you realize you have to do something else. That, of course, is not a great start to the case. It's much more stressful, and you have a plan and you've got to change it.
And you've got to
But
change it. Yeah.
yeah,
Yeah. And the Brompton has really been at the forefront of that, hasn't it? So tell us a little bit about the Brompton as quite a special place, I think.
well, it is. I mean, I couldn't believe it when I got there in 1979. Within a few weeks, Bob Anderson and Elliot Scheinbold had arranged a big international meeting with people, and this was now in the 80s, with people visiting from all over the world, a lot of people from the United States and Europe. Big meeting on all aspects of congenital heart disease. And they asked me to give a talk on echocardiography in one or two conditions. And so I worked very hard, prepared the stuff, videos and stuff, lots of slides. But that was really being thrown into the deep end, being, given 3 months' notice to give a couple of major talks at a major meeting with famous surgeons there, like Francis
Mm.
Fontaine and all sorts of people from all over the world, really.
I mean, these are
John
rock
Kirk.
stars of Peds cardiology, if that
Oh,
can be a
yes,
term.
Yeah, John Kirkland, and from the United States, one of the big pioneers, the first person to operate on tetralogy of Fallot, together with Walt Lillehei. And yes, it was amazing, really.
Mm. And if you think back, can you recall what took you into Peds cardiology to start off with? What was it that had initially, because when you trained, that wasn't a specialty in and of itself, though, right? It was not what it
Yeah.
is today. So how did you get into it, and what was your path?
So there were a few centres. There was a centre at Great Ormond Street. There was a centre in Liverpool, a good centre. There was a centre um, in Leeds, and I was a
Hmm.
Leeds grad. And I was going to be some kind of adult physician. I think I fancied being a neurologist, but I was doing my own rotation, six
Mm.
months in neurology, and some time in actually I did 6 months in pediatrics for some reason, but then I did cardiology for a year. Now in the cardiology, you did 6 months in adult cardiology as an SHO,
Hmm.
6 months in pediatric cardiology with the legendary Olive Scott and Fergus McCartney, who was to become professor at Great Ormond Street. So I was working with them, and I thought, oh, this is very interesting. But the junior staff was me and the other SHO who worked on the adult side. So you had a lot of responsibility even at that time in the early 70s. Interesting. So I thought I liked this. So I then, when I finished that job, applied for a job in adult cardiology, which I got, and
Hmm.
I had a good job, a good teaching hospital job in adult cardiology. And after a year, I saw a job advertised at the Birmingham Children's Hospital Research Registrar in Pediatric Cardiology. I applied for it and I get it. I got it. And I spent 3 years learning and researching and working at the Birmingham Children's Hospital. And it was a busy centre, with one or two good people there, some very good people. And from then on, I uh, I think I took a year, 6 months. I went back to being an SHO in neonatology in Oxford. I went to Oxford and worked with Professor Tizard there, who was one of the great pioneers of neonatology. Spent 6 months there, and then I applied to Toronto and was appointed a Canadian Heart Foundation fellow
Mm.
there. So all my salary, I'm quite a good salary actually. So my salary was paid there, and then so I spent time there, and then I applied for this job at the Brompton Hospital as a
Mm.
senior registrar, and I was appointed there. I'll just I'll just sidetrack slightly because having been to make people envious. So when I was appointed at the Brompton, Jenny Jenks, who was the head of the human personnel, they called it, human resources, said, "Would you like to apply for an interest-free loan to help you to buy a house?"
Oh, wow.
So uh, we were looking at the houses in Chiswick, buying a kind of a two up, two down house for about £40,000, £42,000, a lot of money. So Jenny Jenks said, "Well, we can give you £15,000 interest free."
Oh, wow.
Interest. This is the time when mortgage rates were 10%.
Goodness
So,
me.
so my wife and I got an interest free loan from the NHS through the Brompton Hospital for £15,000. Just imagine what a difference that made to us. No interest to pay on it. And so that set me up, as it were, in the
Gosh.
property market as well. Though in London, in fact, I've lived in 6 houses now, but that was the first house I bought. But thanks to the generosity of the Brompton Hospital and Jenny Jenks, of course, they did give money for
Mm.
people to travel and take up posts in those days. But of course, none of that happens now. There are too many doctors. But in those days, they could afford to do it.
Yeah. I mean, it's changed immensely. I mean, that was going to be my next question to you, actually, because where medical education and training is now is so fundamentally different from even when it was 20 years ago, never mind, 40 plus years ago,
Yeah.
which is probably part of the reason of huge discontent, understandable discontent under, the resident doctors, because there is a huge amount around quality of life. But I think if we just remind ourselves that your on call was 1 in 2, which means one day and night you were on call, the next day you worked without an on call, and the day after that you were again on call, and so on and so forth, which is essentially you lived in the hospital pretty much.
It did, yeah, it did. It was like, you had your own room in the hospital, your own bedroom and everything,
Yeah,
allocated to you only. You didn't have to share the living quarters. You had your own living quarters. One or two hospitals, the living quarters were quite good, but they were very adequate in the Brompton. Nice meals in the boardroom for the medical staff who were on call, with your own chef, that kind of thing.
yeah,
So there were some perks. Um,
yeah.
I, I
It was
guess
a different time, really.
it was a different time, but I guess one of the things is these days there are a lot of
Mm,
doctors, and so the learning environment is very diluted.
yeah,
If you're working,
yeah,
if you're working 1 and 2, you learn so quickly because you're having to do so much. It's a
yeah.
bit, it's different now, and um, as a consequence, people are maybe. I don't think we were paid very much in those days, but there were perks. There were
Mm,
perks. Uh, so I think that people are like, well, it's a different environment. People want to work
yeah,
much shorter hours, and the stresses seem greater to them than they did. I think I get the impression that the juniors are more stressed than I
mm,
used to be, working a 1 in 2, you
Yeah.
know, somehow,
I
somehow,
think you're right. Yeah. Yeah.
um, people would hardly believe it, and I was, not only that, you were working, you were preparing lectures, you were writing stuff, traveling, go away to a meeting for 2 or 3 days, give a couple of lectures, come back. But
Mm.
you had to do it. I didn't have to do it, but I was
Well,
expected
you
to
did
do
pretty
it. 'Cause
much. If you were working at the Brompton, that was not part of the deal, but in some respects, it was a huge throughput, both clinically, academically, and from a research perspective.
correct. Yep,
Um,
that's what
yeah,
we're expected to do. Yeah.
yeah. So, how do you try and mitigate that to your trainees? So, you've been now teaching trainees for literally decades. How do you try and get them to know as much and experience as much as they can in what essentially is less time, right? They haven't got the same amount of time to do it. There's more of them, there's more doctors, never
Yeah.
seems to be enough, and less learning time. So how do you try and do it, and how do you sort of keep the passion going and pass down these uh you know techniques and knowledge?
Well, sometimes, well, I do like talking to people and giving information and what have you, but I had a letter a few weeks ago from two Italian students in their
Hmm.
final year who'd spent a few weeks at the Brompton in pediatric cardiology. And one of them sent me a lovely letter and said, you have managed to show us your passion for the subject of pediatric cardiology, your passion for perfection. And that's the one thing that we've learnt, important thing that we've learnt
Yeah.
from you. You be passionate about your subject. And I am fascinated about congenital heart disease, every aspect, be it the embryology, the cardiac surgery, the diagnosis, the outcomes, the treatment. So, you've been brought up a little bit in that environment. There is an immense
Mm,
interest and passion about it. And if you can show some of that passion to the trainees, that's the way I hope you can enthuse them to
mm,
wanting to learn more. I can teach
yeah.
people, but people have still got to read. A lot of people these days are not reading material, either books or articles on the internet about this and that. People expect to be taught to some
Yeah.
extent. To some extent, you've got to take it partly into your own hands and go and read what people are writing. And
Mm,
so I try, I do try and show my passion for the subject of children's heart problems and their management, and I hope some of
mm.
the time successful.
Yeah, that's wonderful. And actually, going from teaching the students, how do you find that teaching translates to trying to talk to parents? As in, they come to you and they will be at a hugely anxious, incredibly stressful time,
Yes,
and of course, you want them to understand what is wrong with their child in a way that helps them advocate and care for that baby and child to the best of their abilities. How does that piece sit with you? Because it's great to be a good cardiologist and doctor, but you've also got to be this great communicator that is able to bring the parents with you on this sometimes very stressful journey.
yes. I mean, I guess we could spend a whole day discussing this, but one of the things I like to say, or I tell in my teaching, is give parents and families hope.
Mm,
Look too serious all the time. Have a kind of a reassuring smile, and say, I think we can fix this. It's not going to be easy. This is not a walk in the park, but I think we can. And, there's a good chance it's going to be successful. Not certain, but, there's a good chance that it will succeed. And I think taking people along with you with hope, and a smile at the right time and empathy is one of the important things in all aspects of medicine, to be honest. You can't you and and that heart condition is so emotive anyway. So
Very
I
much
think
so.
that's one of the things I would advise to people: give people hope.
Yeah. And kindness goes a long way, of course, at a
Kind
time
of.
of
Yeah, it
stress
does.
and strain.
It does. It does.
Yeah.
So there's no easy answer to your question, darling. But but
Yeah.
and you can't you can teach people a little bit by example, but some people are good communicators. Anybody
Mm,
watching this interview can probably see that you yourself are a good communicator. Some people are naturally good communicators. Some people have got to learn. Some doctors don't never really get to the bottom of it very well, but that's life. That's
yeah.
life. We
Mm.
can't all be good communicators. I hope I
And then
have
do
been.
you, yeah, I mean, you've got a absolutely massive, very grateful patient and parent population. And a lot of kids that you looked after are now probably are parents in their own right. So the cycle continues.
Yeah,
uh, you know um Now that we're in this age of huge amount of data and information available, do you
yeah.
find that that patient and parental connection has changed? Do they come to you with obviously they're on sometimes with more information, but is there any disinformation or misinformation that sometimes they find, and you almost have to kind of undo what they may have thought or found out on the internet or through AI?
There is, but my impression is that for complex heart problems, people are not going to the internet very much, or when they do go to it,
Okay,
they find the whole subject so confusing, so difficult
interesting.
that I think if you're going to the internet about having your hernia repaired, say, well, then that's pretty straightforward. What are the indications? How's it done? Minimally invasive, all that kind of thing.
Mm,
It's quite different when you're dealing with complicated heart problems, and I think it's more difficult to people to get involved or to understand. So I'm not aware of so many people approaching me who said they've read the internet and this is what it says you should do.
mm,
It's quite uncommon. Just occasionally people go
interesting.
and see, yeah, and then may go and see another doctor or write to another doctor by email, what would you do? And they have a slightly different opinion. But it's not everyday stuff. In fact, I'm surprised how uncommon it is. It's even less common than it used to be. Of course, there's so much on the
Mm.
internet, it's almost become less helpful and more confusing.
Yeah. Well, this is exactly why we're talking here, because they will be able to see lots of your videos, which will be very educational and very
Yeah.
informative on children's heart condition. So we'll refer people to that as well, which will be amazing. Um, Looking into the future now, so obviously we discussed a lot of, the past. What do you think the future holds for Pete's cardiology? If you had to sort of see into, maybe another, 25 years, call it 2050. Can you think of what Pete's cardiology might look like then? The treatment, surgery? Are we changing to moving away from surgery? Can we do even more? What's your thoughts?
Well, you can, but there's always going to be a need for major open heart surgery.
Hmm.
One of the things that's clearly going to be important is genetics, because
Yeah.
as time goes on, there's a realization that genetics are more important than was thought. Chromosomal abnormalities that have never been thought of or recognized are becoming more important. So there's going to be a genetic input into this and
Mm,
genetic background to an increasing number of conditions. And once you
interesting.
understand the genetics of something, then you can begin to modify. So I think what's
Hmm.
going to happen is with early diagnosis of fetal diagnosis and with genetics, there will be a period when perhaps the number of children born with congenital heart malformations is going to be falling.
Mm-hmm.
So I would predict a falling in numbers. If you look at some countries, for example, in Denmark, where it's very frequent for parents to want termination of pregnancy for even moderately abnormal hearts. The numbers of cases undergoing open heart surgery there has fallen quite dramatically because
Interesting.
society wants perfection and people are having termination for conditions even that carry a virtually zero operative mortality, but conditions that might require a second or third operation later in life, but nevertheless surprisingly common in Denmark and some other countries, including I think some other countries, but including Israel also, I gather.
Mm-hmm,
So,
mm-hmm.
so difficult to predict the future because fashions change, but
Yeah.
genetics are going to be important in the way people think and manage things.
That's very interesting. So there may be a piece around genetic modification, perhaps, as we're able to deal with, single gene diseases a little bit better.
Exactly.
Um, yeah,
Exactly.
that's
Yeah.
that's a very interesting point. We know that happens to some degree in some of the neurodegenerative conditions, pediatric
Yeah.
conditions, so CRISPR, etc. So that'll be very interesting.
Yeah.
And now that you're going strong, and Mike, I know you're going to be, Pete's cardiology is part of who you are, and you're going to keep going with that forever and a day.
Yeah.
But now that you look back on, a career that's really spanned, 50 decades pretty much, what are your sort of reflections? And to some degree, do you ever think about your legacy? Actually, I know it sounds like a grand term, but is there anything that you want to be remembered by, or anything that you think back, I'm really proud that I did that?
Well, I'm very proud that I've enthused so many people from so many countries in the world. We have so many visitors from everywhere, from North America, many from South America, from Europe, the Philippines, Japan,
Mm,
the Middle East. Year after year, we'd have people from these countries coming to spend time with us. In the early years, of course, they supported the NHS. They had grants from their
mm.
own government. They easily got registration in the UK and they helped with the everyday work. And well, to have been involved in the education of so many people from all over the world has been a privilege. And I feel rather
Mm.
proud of that. And so many people also in the United Kingdom itself. And I guess the other thing is I feel very fortunate to have spent my life being paid to do my hobby. And I've enjoyed every moment of it. So I've been paid to enjoy myself. Granted, I've been paid to work hard, but it's been a fantastic career and a fantastic hobby for which I'm eternally grateful.
Well, I think the patients and all the parents that you looked after, Mike, are grateful in return. And I know that your enthusiasm and dedication to passing that knowledge on to all the UK based as well as international people that come to visit will live on. So um, thank you so much. I'm so delighted that you joined us today. And what we'll be working on with Mike, for all the listeners, is getting lots of his lectures, which essentially cover the whole width and breadth and depth of pediatric cardiology. So if you're interested, do look at those. And Mike, thank you so much for your time today.
Nora, thank you very much. It's been lovely talking to you.